Recording. Good evening, friends. This is the topic on chronic kidney diseases. My name is Dr. Radha Krishna. I have 3 degrees. One of them is Masters in Molecular Medicine. Dr. Srikanth, can you introduce yourself?
Hi, fellow friends. My name is Dr. Srikanth, and I'm a renal medical practitioner from Penang. I'm running a dialysis unit with the integrative medicine in Penang. So today's topic is we're going to talk about the reversal of CKD series. So let's go into this
Part 1.
slides. Part 1, yeah.
Part 1 of CKD series. Step 1.
So we're going to start with the step 1. To understand step 1, we have to go for a classification. First, we have to understand the classification of CKD based on the GFR values. So the chart has been divided there. First description there is 90. So anything more than 90 is considered as normal, or there'll be a slight damages also there we consider as. Number 2, there will be mild decrease of GFR that ranges of 60 to 89 mils per minute of GFR. The third stage will be a moderate or decrease of GFR, that is 30 to 59 GFR, that is 30 to 59 mils per minute. Severe or reduced GFR is like at the level of 15 to 29 mils per minute. And the stage 5 will be kidney failure. Those people have got a less than 15 GFR, so that is less than 15 mils per minute. So there are 5 stages of kidney diseases. 5 stages of kidney diseases. Based on this, you can classify them.
So based on what you have said, that CKD is based on the GFR.
GFR. CKD is evaluated based on GFR.
Okay.
So how do we do this GFR? That's already a blood test. We can test it by blood. So this is something, there's another slide here, which is I picked up from the Malaysian Society of Nephrology. So you can look into that, the first peringkat satu, the first stage, second stage, third stage, fourth stage, and fifth stage. This is actually corresponds to the kadar penurunan, the glomerulus filtration rate. You can see that GFR is reducing. Anything 90 and below, it's considered as peringkat satu, first step. Sorry, the first grade, first stage. The second stage is 60 to 89. That's a gram mils per minute. You can see that. So this is based on the GFR valuations. Third stage is actually 30 to 59. And the fourth stage is 15 to 20 mils per minute. And the stage 5 is less than 15. Anything GFR less than 15, you got to plan them for a dialysis or transplant. Okay. Step 2. Fellow friends, I'm going to show to you guys that this is a normal renal blood. This is a normal renal function test that we do it in our day-to-day practice. This is something that is, I'm not sure whether any other labs. So I'm picking up Gribbles here to do. So this is the test that will be you would have come across with this. So if you see this, this shows a normal renal function. You can see the creatinine there is 55. You can see the GFR there is by about 117. So this is considered as normal blood test. The urea is about 3.2. So this is something that is normal. Okay.
So basically, as a patient sits in the front of us in a clinical practice, the first thing we look at is a renal profile, and this is a normal test.
It's a normal
this is the abnormal test.
Yes, so this is the abnormal test. If you're looking into this abnormal test, the first thing that goes into your eye is, remember I told you the first step that we have to evaluate by looking at the GFR. Friends, you can look at the GFR there. eGFR is 58. Creatinine is about 111. So when you're looking into the eGFR assessment there, the description shows a stage 3A. So the GFR values is actually 58. So that follows the stages of the stages of CKD. So this patient basically having stage 3 CKD.
So
This is
certain
how you
labs
have
will
to.
give CKD 3A, 3B.
Yeah,
Some labs
3A,
don't
3B.
even mention that.
They don't mention actually. Yeah, that's
Okay.
true. That's true.
Step 4.
So step 4. Okay, there's another test that we do very specific test. There's something called as a microalbumin test. So in a government settings and all that, they call it as a PCI. It's a protein clearance index. Otherwise, you can also call it as ACR. It's called as a albumin creatinine ratio. So this is a urine test. You can actually test them ahead before they even get into a macroalbuminuria. Before that, you got to pick up earlier by doing this test. So you can do this test like a random, like anyone, you can actually do it, but test it for ACR, not urine FEME. Urine FEME.
This is one of the 2 important tests we do in a CKD
Too important.
patients.
Yes, this is a two important thing that you do for the CKD patients.
So what does it signify, Doc?
This significantly, they will say that, can you look into that, Dr. Radha? It's like urine albumin showing that it's no more than 21. That means it's 301 milligram per deciliter. That is a very high level. That means that there is a leakage of proteins into the urine. And when you're looking into this ACR ratio, that falls 24.6 milligram albumin. That means the patient is pouring heavy protein. That means there is already a leakage at the kidney levels. Which part of the kidney that is causing leaking? Commonly, it's at the Bowel capsules and the nephrons as well.
Step 5.
Yeah.
Step 5.
Okay, then go to step 5. Okay, step 5 is the biomarkers of kidney functions. The thing is, we also have to bear in mind, there are certain tests that we can do, but specific tests, the most specific test you wanted to do for CKD to find out is by doing something called a cystatin C. Okay, what is cystatin C? Many people actually. Okay,
what does cystatin C signifies?
It signifies that a test. It signifies that whether you are doing a kidney test. I mean, you are doing the early detections of kidney failure. You are picking up way ahead a kidney failure, and this is actually very, very specific marker compared to the serum creatinine that we are doing. It's a kind of a biomarker test that is evaluate the kidney functions and early detections of kidney damages.
So if I follow you right, Doc, we do cystatin C and ACR in CKD series or CKD4 to have a biomarker, the damage.
The damage, correct. Okay, so this is another slide that put it here is because when you're looking into this renal dysfunction, right? So you can see there's many other factors that governs this, that is contributing to raise of cystatin C and all that. So the main thing why I ask you this, you can see that, C-reactive protein, inflammation, this is a common test that we do in our labs and all that. So this is actually also can causes kidney damages. If you guys can see that, any pro-inflammatory cytokines or the patient having a dyslipidemias, hypertension and all that, please do screen for cystatin C, because this is a marker that gives you a lot of information.
This is a real test.
Hello friends, this is a real test that you can see there. Serum cystatin C, and also we do assessment by, there's another test also comes into that is eGFR by cystatin C. And there's another test also you can, you compare to before, the test is EGFR by the renal function test. And this is EGFR by cystatin C. This is way more accurate than that. Because creatinine is influenced by many other factors like sex, body mass index, muscle mass, dehydration levels, and all that. But cystatin C, it's the specific marker, and it's only estimated to pick up the CKD of the patients. Step 6.
Okay, step 6, this is where I take over. I'm Dr. Radha Krishna. I've been training doctors past 10 years. The most common causes of CKD will be hypertension and diabetes. These are the most common. Endpoint of both of them will be CKD. So step 7. So step 7, when you imagine ourselves, we are sitting in front there and a patient sitting in front of us. What are the first few things we want to do in the terms of reversal of CKD? Okay, if you look at that, they may have inflammatory factors because the methionine does not convert to homocysteine, or homocysteine doesn't convert to methionine. So you need to correct the methylation. The key is methylation. Methylation means you can give a methylcobalamin or vitamin B12, which half-life is around 6 to 7 days. You give weekly. That helps to correct the blood pressure very fast. Methylation is one of the major problems in CKD. So that is step 7. Step 8. So as the patient is sitting in the front, one of the most important factor is the gut. Okay, the first step that we do in terms of clearing the amount of creatinine or urea or uric acid will be the intestines. So in the intestines, there's a bacterial overgrowth, and it's called SIBO, small intestine bacterial overgrowth. Okay, this is a test we have done, which regularly I see a lot of bacteria. As a GP practice, we will not be able to see unless we send a test like it's called DMSA to see screening, and it will cost you a lot. But for me, it's on the spot. I can see bacteria. I have done more than 10,000 of these kind of tests to see bacteria in CKD patients. What does it mean? If you look very carefully, these bacteria can be causes what you call a dysbiosis, or it can come from oral dysbiosis. Okay, they causes local and systemic inflammation. And these lead to pro-inflammatory cytokines, oxidative stress, gut-related uremic toxemia, toxins, gut permeability, urea flux, and traditionally uremic toxins. This is the key factors that we are watching about. Any inflammation we have to reduce. In CKD4 to convert to CKD3, we have to look at every indicator to remove inflammation. So there are more than 20 inflammatory factors. So I'm just running one of few of them. Okay, this is where the CKD oral gut kidney axis. Okay. So the bacteria, what it does is when it breaks down, the last product is called LPS or lipopolysaccharide, which is 100 times more inflammatory than any other things. If you are looking at blood tests, we do HSCRP. HSCRP is not specific. It's non-specific, but LPS will lead up to inflammatory, like increased amount of tumor necrotic factor. Interleukin-6, HOMO IR increase, insulin resistance is decreased, sensitivity is decreased. So these are the factors that we don't see. Nowadays, when you do a blood test, they will show you interleukin-6. I don't see these being done in many other places, but at least our intelligence will tell that if there's an excessive amount of bacteria, these are the leading factors will happen. So the first thing that the patient is sitting in the front, that we need to clear these inflammatory markers. So what do we do? Okay, you can see interleukin-23, interleukin-6, interleukin-1, tumor necrotic factor. You got COX-2 and interleukin-17. Can you see so much of inflammation going on? So when the patient is sitting in front of you, inflammation is converted to these are the cytokines is converted. Hold on. Okay. Next. So what we do, the first thing we want to cut down inflammation is to give an antibiotic. This antibiotic should be a gram-positive, gram-negative antibiotic to clear the bacteria. How long do we give? For example, I give Augmentin, 625 milligrams twice a day for 5 days. to clear out all the inflammatories. We have to take off the excessive inflammation. If I'm sitting in the front of the patient, and if you don't have the test I have, this is the fastest we use our known fact that we have to clear out bacteria. So do not give ampicillin. Ampicillin is a Second World War drug. It doesn't act. This patient may have been on multiple antibiotics. This is the reason you have to give gram-positive, gram-negative antibiotic for the first 5 days. During the same period, the step 9 will be, you see all these are parasites. We are not sure which parasites we are addressing about. Okay, so the parasites, if you watch very carefully, they also trigger inflammation, from macrophages to interleukin 10 to interleukin 4 through the dendritic cells. You see all are inflammatory markers. And maximum we look at a blood test and we look eosinophils. Eosinophils may not be specific. It can be allergies. It can be so many other things. There can be histamine release. For this reason, we clear out the parasites using, and it can be, these are the parasites in the body we don't see. Okay, we are not testing it for it, and we don't have time because the time is against this patient, because his time versus his recovery. We don't want him to go and end up with dialysis. So what do we do? We can give albendazole. Please, albendazole should be given 400 milligrams daily for 3 to 5 days continuously. Or you can use albendazole mixed with ivermectin. There's a combination. Or you can make albendazole with flagyl. Okay, but again, the patient is CKD. You must understand when you give flagyl as such, it causes nausea, vomiting, or there's a change of color of urine into dark brownish, and they panic. So the best what you do is the first step. Along with it, I give a B12 injection, 500 micrograms weekly for 4 weeks. Then I clear out the bacteria. Then I clear out the parasites. The reasons I've actually showed it to you because of a lot of inflammatory markers. Step 10, you can see this is fungus. What does fungus do? Fungus, if you look at it very carefully, Candida albicans, it doesn't do anything on the surface of the mucus. Once it puts a hyphae through, it attracts macrophages. Macrophages trigger interleukin 1b, interleukin 6, you name it, tumor necrotic factors, CXCL 1, 2, and you can see it attracts other factors into the system. So there's a massive autoimmunity going on. So we need to clear fungus. Fungus, we have to be very careful because there are a lot of byproducts of fungus. The 3 byproducts it produces is, one is ethanol, uric acid, ammonia. Now these patients have got very high urea content, and uric acid is very high. And we didn't notice that can be an overgrowth of fungus. For that reason, ethanol has to be cleared out. So the patient will have a sleepy head, not active. Uric acid may be added on to your urine renal profile, and you may have mistaken it for the regular uric acid. It may be coming back from fungus. And ammonia is another thing that has to be cleared out. For that reason, we treat what do you call? We treat fungus using nystatin. Nystatin does not enter the systemic circulation. Cystatin only acts in the gut. So we give 500,000 international units 3 times a day for 15 days to a month. Or you can give diflucan or fluconazole. Fluconazole, we have to give weekly. And again, we have to be very careful because this patient is already compromised in terms of
GFR.
Yeah.
The GFR.
No, immune compromised because GFR will be affected. If you are irregular on fluconazole, they build is resistant to the drug, and they form a biofilm around it, and they become resistant to fluconazole. So that's why you have to give weekly, or we can defer fluconazole or diflucan until we clear out other factors first. Okay, fluconazole 150 milligrams on day 7. That means when you have started on antibiotics, 5 days, give a day rest, day 6. Day 7 is when we start step 11. That means we are now watching the intestines. Why the intestines are important? This is where all the trash is formed. Ammonia, urea, creatinine, inflammatory markers, massive. So if you look at the end-stage renal failure, renal diseases, if you look at the left side, there's a decrease in the beneficial bacteria, but there's an increased amount of bacteria that which produces with the urease, uricase, tryptophanase. So if you look at the bacteria, the whole bacteria, and you look at the right side, you have gut bacteria-derived uremic toxemia. This is where I want you to focus. It forms uremic toxemia. And there are 5 components of it. It's called indole, indoxysulfate, acetic acid, p-cresol sulfate, TMAO, and phenylcysteine. Okay, you can see it during the digestion, you form p-cresol. So this is where the CKD, the kidney gets damaged when the nephrons to the tubules, and there's an overload. So this is causes uremic toxemia. This is where, when we look at our blood tests, we will look at HACRP. It's an inflammatory marker, but it doesn't show all these. Okay, so what do they do? These are the 5 components that we are talked about, and it can cause accumulation in the CKD. It has toxic effect. It acts on the renal cells, including tubules effect and the glomerulus podocytes, and also leads to cardiovascular complications. Okay, you can read more details on this, because this program is for half an hour only. Okay, and so now step 12 is that we check the engine. What is the engine? The engine is the inflammatory markers. If you look at very, very carefully, you have hold on, you have all the inflammatory markers from polyol pathway, PKC pathway, that means protein kinase C pathway, all the glucolysis pathway, hexaminic pathway. You can see that vascular growth endothelial factors, angiotensin 2. If you look at the inflammation, the whole list of inflammatory markers are there. Question is, in our blood test, it doesn't address this. And there's massive amount of oxidative stress. And this leads to either diabetes or hypertension. So these are the things that we want to clear first. Okay. So to clear out all these inflammatory markers, we are using RK0, or is an anti-inflammatory. It addresses tumor necrotic factor, interleukin 1, interleukin 6, into the tumor necrotic factor. So all you have to do is, for the moment, we just give 2 capsules daily, because this patient is already overloaded with all the drugs. He'll come with a whole list of drugs. So to address this inflammation, you can see all the inflammatory markers. We are using RK0. In your blood test, it doesn't show any one of these tests. I feel sorry for that. So we are looking blindly at the patient. The patient is sitting in front of A, is asking for life. Doctor, can you help me not go into dialysis? So we use our intelligence to know there's an inflammatory marker, and this addresses all the inflammatory cytokines. Okay, and it has got no side effect at all. Okay, and you also, of course, involves a dietary modification, probiotics, and absorbent therapies. That comes later. Step 13. What is step 13? Step 13 is that we clear out the bowels using a product called Royal Detox. Okay, I will give you the context later where to get it. It comes in a bottle. Got a very nice Assam taste, or a taste which is nice. So what you need to do is, these are the contents of the Royal Detox: amaltas, rosella, and ginger. So what it does is, you take, after we clear the bacteria, parasites, and the fungus, immediately after that only we start on Royal Detox for 5 days. They take daily 1 bottle daily for 5 days. What happens is, after 4 to 6 hours, the person will start going down to the to pass the BO, the pass motion. He'll come in small quantities but frequently, and is foul smelling. Absolutely. So this way we reduce the creatinine level very, very fast, and the urea levels, because remember, these will help to clear out uremic toxemia in the small intestine and the large intestine, especially large intestines. I need to get stand corrected. So you have to do this daily for 5 consecutive days. In a patient with CKD, we have to be very careful about the fluids. Okay, so this patient, when he's passing motion, we also need to adequately hydrate him. Okay, the patient may be or diabetic or hypertensive, the patient may be on insulin. So you've got to be careful on bed wise. Sometimes we may not give the whole bottle, we give half a bottle. So what Dr. Srikanth and me did is we have tested this methodology, giving antibiotics step 1, giving a B12 injection, antibiotics, antifungal, parasites, and then we detox using these for 5 days. And with subsequent blood tests showed the urea drop, the creatinine levels drop. And it's amazing to see how fast. Step 14 is day 6. Day 6, that means we completed the antibiotic, we completed the fungus, antifungal, antiparasites, then we gave a royal detox. After completing royal detox of 5 days, day 6 is when we give RK Restore. Okay, so what does RK Restore do? Okay, it took me 10 years of research based on thousands of tests. I have reformulated it and we are successful and extremely successful in unbelievable recovery. Okay, so it consists of 2 capsules, the new version which is coming up. In these 2 versions, it has got just multivitamins, multiple minerals, antioxidants, amino acids, pre, pro, and postbiotics. What does it mean? So what does RK Restore do? It corrects the mitochondrial dysfunction. If you look at the oxidative stress, it is basically because of oxidative mitochondrial dysfunction. So it corrects, the first step is it corrects the mitochondrial dysfunction. Second step, if you look at the previous slides, it has oxidative stress. So this clears out the oxidative stress. Then, like what Dr. Srikanth have told, that most of the tests which we have done over the years, we found that 10 out of 10 patients have toxic metals. So it will kill out toxic metals. And it removes chemicals, especially microplastics, very common in CKD. Then it also corrects the cell nutrition. It repairs the intestine. It also helps to overcome fatty liver, which is a common problem in CKD. Plus, if you have taken this product for for a period of 6 months, what happens is the body will produce its own stem cell to heal this patient. So these steps are very essential to you for us to understand. So in the Restore, you have the prebiotics. These are the prebiotics, and it has got amino acids. Okay, why amino acids? Based on thousands of tests, I have found patient having tryptophan deficiency, tyrosine deficiency, methionine deficiency, histidine deficiency. So this prebiotic is basically having all these 12 amino acids that replaces the gut because the gut bacteria has to produce some of these neural factors or required by the gut to translate into thyroxine and everything else, neurotransmitters. Okay, and the probiotics is these are the regular. So once we have killed all the bacteria in the gut, giving antibiotics and the parasites and the fungus, we need to replace the gut with good bacteria. So if you look at RK Restore, it has got the prebiotic, probiotics, and the postbiotics. What is postbiotic? Is the food for the bacteria. It's a butyrate. So it converts the short chain fatty acids. So this way, the uniqueness of RK Restore, it has got pre, pro, and postbiotics, which no other product has similar thing like this composition. Okay, so this is the tribiotics coming up soon. Okay, and question is, how long should we carry this particular formulation, or how long does it take to continue this regime? Minimum you should take this regime is 3 months. The dosage and everything else, how frequently, you can always call me and find out. I'll give you step by step, because this is only a concept that I'm showing. This is the methodology we have been using the past probably 2 to 3 years, and we have fantastic results. We are able to pull through a lot of patients. And to recap, basic impact of gut on the microbiome, fiber rich. Okay, we must cut down on animal proteins because it produces a TMO. Fermented food, polyphenols, phytonutrients, probiotics, and dietary impact on microbiome. Microbiota is one of the key factors to help to overcome CKD. That's a missing part that most of us fail to do. Okay. And I welcome Dr. Srikanth back onto the stage. He is one of the two real cases.
Okay. Thank you, Dr. Radha. Okay, fellow friends, you can have a look on this test. This is my patient who has, Chief, please put the other slide, Chief, not this, the
Okay.
other one. Okay, so this is the test that is a 70 years old man. You guys can have a look on this GFR stage. I mean, you can see the creatinine, which is 111, and eGFR is about 58. So as what Dr. Radha was actually telling, the stage is actually 3A. So they got panic and they came down and, look at me. I mean, I've started the same regime what Dr. Radha was actually saying. The patient is, I think if not mistaken, this patient has got a hypertension and also diabetic. So basically, his sugar was an issue. After some times of detox, royal detox that what I've used, and I've also have used for the RK0 and the Resto. And this is the result. You can see that the patient is reverted to stage 2. So the creatinine has, you can see the GFR has come up to 69. So this has happened in about a short span of time. So you can see that the patient's leg swelling is done, I mean, he actually regained his appetite back again. Patient is quite happy, and I've removed some of this medication as well and slowed down. So basically, what I'm trying to say is, with this regimen, what we are using it, you can actually, reverse the stage of CKD to a certain level, but you got to follow the regime as what Radha said, the dietary part, the fluid intake part, restrictions of the proteins and stuff like that, salt and all that. So it is doable if the patient is really cooperative, lah.
Thank you. Okay. So now
Next.
coming back to step 15, we need to see progress. So progress is based on the renal profile of urine test. If you are in a hospital setup, in an intensive care unit, they will do renal profile daily. In the ward, sometimes we can do weekly. So if the patient is in stage 4, I suggest you to do renal profile weekly to see the progress. Sometimes it may go up, don't panic. Okay, the urine test you can do daily. They can do a dipstick, but renal profile you can do every 2 weeks, weekly or every 2 weeks or once a month. During the once a month, apart from the renal profile, we also do ACR and cystatin C. So the important thing as we do weekly, we can assess what to remove, what to add, what are the other things that we can do. It gives us a guidance. Okay, and I've seen many of our doctors whom I guided them on phone, they themselves were so surprised. I can show you some of the findings they have done. They're able to reverse CKD, which they have never done in their life. Okay, so this is one of the gut pages I've developed for one of the companies. Okay, to show you one shot what are the gut changes going on. Okay, no one has a similar a test like this in the world on the spot. So other important factors in the subsequent series of CKD will be what are the dietary changes we need to do? What are the salts you need to convert it to potassium salts? Then we also learn how to remove phosphates, which is a problem in CKD. Then diabetes being the main key factor causing renal diseases is the first thing that we need to reverse, not hypertension. The moment you reverse diabetes, right, like overcoming the insulin, removal of some of the drugs, hypertension automatically comes down because all these causes oxidative stress, which in turn causes the endothelial nitric oxide synthetase dysfunction. So once we correct that, automatically the blood pressure comes down. That is the reason we're asking you to do a B12 injection. Then we also help you understand where the urea pathway takes place. For example, urea cycle starts from the liver, not the kidney. So once you clear the fatty liver, automatically the urea comes down, and creatinine levels will pathways I'll teach, we will learn together over the series of CKD series. The gut microbe we will also go through in detail, how to remove toxic metals and chemicals in the body. These are the series we are going to do one by one. This is a half an hour presentation. My name is Dr. Radha Krishna, and please understand I'm a regular doctor like everybody else. My experience must be spread over the period of time to all the doctors. So if all the doctors who are attending here, if you're not sure of what is it all about, or you're not able to follow, I will have recorded this video. Go through it slowly, one by one. See it many times. This has taken me more than 10 years to develop a series of a step-by-step pattern of how to reverse CKD. Okay, so a helping hand is better than a praying lip. What I'm trying to say is the patient sitting in front of you is asking for life, and you and I have the knowledge, and we are using our knowledge to heal them. You don't have to be a specialist to learn the specialization. I can teach you basic things to help the patient. Beyond certain extent, of course, we're going to use the urologists and the nephrologists to help us out. But at the basic stage, a lot of patients will come and say, Doctor, I don't want to go to the hospital. Can you help me? I don't want to do dialysis. Can you pull me out? They're pleading with your body. They're bargaining with your life. You're not treating the patient. You and I need to understand we are treating our entire family. The person can be the main earner of the family. You are giving them a life. So I'm willing to help out one-on-one. Anytime you can ask me. I'm a regular doctor friendly. You can always message me. I can re-explain the thing, the entire series one step at a time, slowly, and tell you in detail how to go about. This is a uh, general steps of 15 steps, how to go step by step. More detail than that, you need to get back to me on WhatsApp. Thank you so much.